the next speaker does not need really introduction, and Stefan Paepke is one of the surgeons from Munich, from Germany, and I can see that Stefan has started to share his screen, and he's going to give us some data about Magtrace in post-neoadjuvant chemotherapy patients. Stefan, the screen is all yours for the next 20 minutes.
Okay.
Presentation.
Yes, thanks a lot. Yeah, I would say everything was said by Andreas. What we have seen over the time in what I'm using, Magtrace and Magseed, it comes very easy to our clinical routine. And what he has said is we have two problems.
Stefan,
by the way,
Stefan, we cannot see your slides. We can see only your desktop, and we can see the folder, but not the slides.
Neue Freigabe. Better?
Better, and if you make it full screen?
Yep.
That's beautiful. Yeah, that's
perfect. That's okay. Good. So, what Andreas was pointing out, that we are, as surgeons, we are focused on targeted surgery. The times are over in which we go for mastectomy. So what we are going for, and that is related to primary systemic chemotherapy too, is we have to visualize the tumor in the breast before, during, and after neoadjuvant chemotherapy, and the same is for the axillary lymph nodes. And what we established is I would say that what Andreas was pointing out, the MACU system in patient whom we do the biopsy for taking the tumor biology. The second step is to place a clip or a seed, and the same thing is for the axilla too. So we have different opportunities, and in Germany, and that I would say across Europe, it is more or less usual to bring tumor clips, O-twist markers, and something in the axillary lymph nodes and in the breast. And the problem in the context of neoadjuvant chemotherapy is that if you have a partial remission or a complete remission, it is very difficult to see the clip via sonography. That is fine for the breast, because you have the ability to go for wire marking with the radiologist, but it's not so fine for the patient with clips in the axilla, because you don't have the opportunity with the sonographic guidance. And so what we are tested was all these things around primary systemic chemotherapy in our guidelines. These are the new guidelines from March 21 regarding breast preserving surgery. The image supported wire marking is with a double plus, and all the other different markers, seeds as magnetic seeds, radar reflection, charcoal, they have a plus minus. It means you can do that, but it is related to the question of do it in registries, and so we are doing. And for the sentinel lymph node biopsy and for the target X-ray dissection is the same. A technetium is the standard technique in Germany, across Germany, but we are able to go for patent blue, ICG, and biotechniques too. And in the context of neoadjuvant chemotherapy, we have and I come later back to these slides. We have the opportunities to go for what makes the false negative rate lower. To take more, is that a good idea? To take more sentinel lymph nodes, you are in the knee of the X-ray dissection, and that's the area what we came from. Targeted surgery, targeted surgery, targeted surgery. So you can use with dual markings, all the things, but the aim of the game in normal surgery and surgery after primary systemic chemotherapy or endocrine therapy is to find the target and to have the same good false negative rate and all the results what we have. The data or as I would say, the pioneers in Germany, where Maria Carsten from the Charité, she was early involved in the Maxi techniques, and Mark Till from Frankfurt, he was the early beginner with years ago with Sienna, and they continue their work. And what we have seen is that we go for clinical routine after a couple of weeks or months coming from technetium and patent blue marking. Maxi is confirmed and approved for breast lesions and lymph node localization. And the localization is done by the Centimax system. And the same is for the sentinel lymph node biopsy via Magtrace and the X-ray dissection. So what we did is we compared two groups in a retrospective analysis. The comparison of our standard technetium group and the SPEO-guided sentinel lymph node biopsy in patients with neoadjuvant chemotherapy. First retrospective data, and what we have seen in our clientele was in a patient without the context of primary systemic chemotherapy, the logistics is absolutely much more better with these biotechniques. And what the data also was saying, the detection rate and the efficacy rate is nearly the same. It is over 94% in our clientele, but we didn't confirm until now that in the neoadjuvant setting. And Germany is a country of neoadjuvant primary systemic chemotherapy. Across Europe, we have the same strategies. All the people with triple negative breast cancer, with HER2 positive breast cancer, and luminal B cancers with a high rate of proliferation, all these patients are going the pathway from the primary diagnosis to chemotherapy and then coming to the OR. Using the data and the experience from our colleagues from Uppsala, we changed completely in the early time from Sienna to Magtrace, and not 2 milliliter, only 1 milliliter. And what we did in our first data set, 55 patients, 29 with Magtrace and 26 with technetium, treated with breast conserving surgery, treated with nipple-sparing mastectomy and mastectomy. And we are focusing on detection rate of and number of lymph nodes, what we have to remove. Our application technique is, by the way, I'm an ultrasound guy. We took the breast surgery years ago because we are able to do sonography by ourselves. And so I'm able to, with the high-level ultrasound devices, I see the tumor, I see the calcifications, and I can do it by myself to inject the Magtrace, as Andreas was pointing out, peritumoral or intratumoral. By the way, this technique minimized all the problems what was mentioned in the literature before regarding staining, regarding MRI problems. If you inject the Magtrace only 1 milliliter in the tumor or really in the knee of the tumor, and you remove the specimen, you remove the segment, you remove all the overload of iron-based solution with the specimen too. I started because it was absolutely fine in my personal logistics. I started to applicate and inject the Magtrace immediate before surgery. That means 20, 30, 40 minutes before surgery. And I changed our technique, and we went to inject 1 day before, 2 days before, or a week before, when the time point was defined when I'm seeing the patient, and the patient is coming to our clinic, and we prepare all the things for the surgery. We discuss with the patient, and in this moment, I go for the injection of the Magtrace. The age of the patient in our data set between 24 and 80 years, and the sentinel lymph node detection rate, and that is in line with the literature with bigger patient sets, was 96.6 for the Magtrace group and 85.2 for the technetium group. That means it is not really non-inferiority, it is superior. It comes from two aspects. You are combining a signal with a staining. So you have this idea of dual marking in one technique. And the number of removed lymph nodes, you remember the data from Abigail Caudle from the MD Anderson, and what we have seen in the literature, take more and your false negative rate is decreasing. Good idea. But to have the exact number of lymph nodes, what was involved or what you want to have, is an important issue. And what we've seen in our data set is in the Magtrace group, the median number of lymph nodes was 2, and in the technetium group was 3. Okay, the clinical relevance is doubtful. I don't know. We didn't measure any effects regarding lymphedema and so on and so on. But if the median is lower, that means indirect that the idea of targeted therapy is more focused. What also coming from the literature, I'm very focusing to see, okay, what is regarding staining. And what we have seen is staining is reported in 6 of the 29 patients with Magtrace. And severe staining, that means grade larger than grade 5 of a 10-point visual analog scale was not reported. It was only reported as we started with the Magtrace application subcutaneously, what we are leaving immediately. Once again, the comparison, take more lymph nodes. What you have seen here in this slide is the overall false negative rate. If you remove more than 3 sentinel lymph nodes, was in the ACOSAC 9.1, in the Sentinel trial 4.9, and in the French group 4.5. That is, I would say, that is our target area. We want to go below 10% with a false negative rate, and it was possible with in the Magtrace group with in the medium to remove lymph nodes. As we discussed our results, first of all, and it is perhaps it is boring that we are repeat these things in a redundant way, but the logistics for us as surgeons is so brilliant that I can imagine that the people are focusing later on the technique with the implementation of a different clinic from the nuclear medicine. It takes in our hands, in our clinic, that's more than 4 hours. The people from the nuclear medicine, they are very involved in this technique. They inject the technetium perioral subcutaneously, and then they are waiting and waiting and waiting. And during the patient is waiting, I'm waiting too for the patient. So that is ruled out by the Magtrace technique. It is feasible. What we have seen is that the reduction from 2 milliliters to 1 millimeter is absolutely effective. In all the comparisons what I have seen, in our, I would say, summary was that Magtrace is already well established in our clinical routine in our group as an alternative to technetium-based procedures. And what I've seen in different hospitals in which ICG-based procedures are implemented, it is it is really not only an alternative. For my personal feeling, it is superior to in comparison to the different techniques. What we have discussed with Endomag, that would be a good idea to implement all these techniques in the Axilla registry. Axilla is a big registry from the EU breast. That is a registry coming or focused on all the endpoints regarding lymph node removal, sentinel lymph node detection, removal in relationship to primary systemic chemotherapy. And if we are talking about primary systemic chemotherapy, we are also able to use the MACT technique to mark the biopsied lymph node in a very, very early way. What I pointed out, it is greatly simplifying all the coordination and logistics in patient treatment, and you have the benefit to find the sentinel lymph node guided by visual orientation because of sustaining and of the signal. So what we have seen is that is a combination. That's what I said as I started with the lecture. If you have more or less signal and staining in one, so it'd be one fits all idea. What is behind the idea of dual agents? So that is independent on time. That's what I pointed out. You have 6 months for the MACT technique. You have 7 days for the Magtrace technique. You are with the Sentimag probe very focused and highly accurate. It is a distance-based detection. And what I said, it is implemented in Axilla registry so that we will have in a year or 1.5 years, what I've seen from the last data set, more or less 1 to 1,500 patients. And then we are able to, I would say, analyzing all the and focusing all the problems regarding sentinel lymph node target X-ray dissection in the context of primary chemotherapy. Once again, pain. What we did, because I started this with local anesthesia the day before of the patient schedule. It was reported in the literature that the pain scale is around 3 to 5. That's also what I have seen, and we did some MRIs to check if the resection is complete immediately after primary surgery. And until now, I don't see, or our radiologists don't see any restriction in sensitivity and the detection in the aftercare imaging. For us, an MRI is in Germany a part of aftercare program in patients with uncertainty regarding scar or local recurrence. MRI is indicated in these patients, and so it is necessary to have data to see, okay, there are no problems regarding sensitivity and detection in this field. Thank you for your kind attention, and to the Q&A session, we are ready to answer your questions when we have heard all the lectures of the day. Thank you.